everyone. We'll continue with the incontinence from the previous video, part 2 of the gynecology. So, we have known about different receptors that are present on the bladder and their effects. So, how are we gonna come to know what kind of incontinence they are talking about? So, first of all, we'll see the history. How much fluid does the patient take and how much fluid is produced in the urine, and if there is urge with a physical activity like due to any stress, or the person feels like she or he needs to go to toilet very fast, and this will suggest the urge. And if there is incontinence with physical activity as well as with urge, that is mixed kind. And if there is continuous loss of urine day and night, this will suggest there is some fistula has developed between uretrovesical fistula, vaginovesical fistula, that has lead to the direct urine is dribbling out of the vagina continuously. Now physical examination, what we can see, we can see abdominal exam for any mass or ascites, if there is any organomegaly that's there, and we can see clitoral sacral reflex, that is when we brush the labia majora, the clitoral sacral reflex, we brush the labia majora or tap on the clitoris, and that causes the reflexum external anal sphincter muscle. And so we'll see if it is intact. We'll do pelvic examination for any inflammation, infection or atrophy due to postmenopausal, and if there is any increased sensitivity of bladder to that is leading to the frequency or dysuria. We'll see any vaginal wall is prolapsed, either there is cystocele or rectocele that is causing pressure on the urethral passage, and we'll do a Q-tip test for the assessing the hypermobility of the uretrovesical junction. So there is bladder and then there is urethra. So this junction hypermobility we'll check, and we'll ask the patient to lie down in a supine position. We'll place a sterile, well lubricated cotton tip swab in the urethra. The angle should be less than 30 degrees from the horizontal, and if there is no adequate bladder neck support, the angle will be more than 30. Normally it should be less than 30, then it will be more than 30. So this is how we diagnose it. Now for other things that we can do urine analysis and culture. We can see for if there is hematuria, and hematuria due to any cancer or foreign body or tumor, and we can do cystometric volume measurement, that is post void measurement if it is less than 100, and normally that should occur, and sensation of fullness should start around when it is on around 200 to 250 ml, it's full, and urge should occur around when it is filled 400 to 500 ml. So this is how we can this is the normal cystometric volume examination findings. And what we do, we empty the bladder with the urinary catheter, and then we infuse it with normal saline with the retrograde infused with normal saline, and then we see how these findings, the post-voidal volume, the sensation of fullness, it occurs at what volume, and at what volume they have urged to void. So if the residual volume is very low, if it is less than 100, then we can see that it's okay. It can be urge incontinence because it's getting and she's getting it very low residual volume. She's getting feeling of voiding, that can be urge incontinence. Then there is sensation of fullness, and then and there is urge to void normally 400, 500 ml. And we can see if there is any involuntary bladder contraction. We can watch it by watching saline level in the syringe rise or fall. In the absence of contraction, it is normal. So with involuntary detrusor contraction that occur with causing the urge incontinence, there is saline level in the syringe goes up and down, okay, because there is a contraction again and again, and they're occurring one after the other. Then there is stress incontinence. We can learn that there is involuntary loss of urine with coughing and sneezing. And Q-tip test we can see is positive with the hypermobile uterus, in which there are hypermobile uterovesical junction, and so this is how we diagnose incontinence. And main thing is the treatment that we do with management, that we only know Kegel exercises we can do for the stress incontinence and estrogen replacement if there is postmenopausal women. And surgical therapy can be done to elevate the urethral sphincter, so that it is again an intra-abdominal location, that is urethropexy. And it is done by attaching the sphincter of symphysis pubis using Birch procedure, as well as Marchetti-Kranz procedure. The success rate of both of these procedures is around 90%, and they are minimally invasive procedures, surgical procedures. And there is tension-free vaginal tape procedure, in which a mesh tape is placed transcutaneously around and under the mid-urethra, and it does not elevate the urethra but forms a resistant platform against intra-abdominal pressure. So this formation creates, there is a break of transmitting intra-abdominal pressure to the urethra, so there is no stress incontinence. So we studied about two important procedure: Marchetti-Kranz procedure and Berg procedure, and the urethropexy that we have done, and the non-surgical Kegel and estrogen procedures. Now what about the hypertonic incontinence? And that is motor urge and most common incontinence in the older women. So it is due to involuntary rise in bladder pressure, and this occurred due to idiopathic detrusor contraction, and we cannot suppress them voluntarily, these contractions. So what we will investigate, everything will be normal, the urinalysis, culture, everything. But cytometric study will also show a normal residual volume, but involuntary detrusor contraction are present even with a small volume in bladder. We see the fluid level in the tube goes up and down. And what is the management that we have already said? Anticholinergic medication, oxybutynin. And mixed, there is both type, and we already studied stress and urge. So it will be Q-tip will also be positive, and pudendal nerve innervation will be normal. All these findings will be normal, except in the cystometric studies, the sensation of fullness and urge to void volume may be decreased. So we can treat the pathology. And the functional incontinence occur with older women, and these are mainly due to women with increased or advanced age suffering from arthritis or Parkinson's, or those who are psychologically challenged like in Alzheimer's or dementia. And there is nothing wrong, there is no involuntary contraction, every lab investigation is same. They just have inability to toilet oneself in a timely fashion. So there is loss of urine can vary from small leakage to full emptying of the bladder. So what we can do, we can treat them, possible we can give them like a bladder training, that they have to void timed voiding that we say, and some pelvic floor exercises. And with overflow incontinence, there is rise in bladder pressure occurs gradually from the over-distended and hypotonic bladder. And when the bladder pressure exceeds the urethral pressure, then the urine is involuntarily passed out. And the blood and the and that but only until the bladder pressure equals the urethral pressure that the urine will come out. Then the bladder will not empty out completely, and the same cycle will keep on going. So this is normally caused by denervated bladders, that is, we say neurogenic bladder and diabetic neuropathy, multiple sclerosis, or any systemic medication we have given like anticholinergics. So the urine will come out intermittently in small amounts, and this can occur both day and night. And what we'll see, the anatomy is normal on examination, but in neurological examination we'll see pudendal nerve sensation will be lost, and the other studies will be normal, but cystometric study will show marked increased residual volume. And what we can do with these patients of overflow incontinence, we can possibly do intermittent self catheterization to remove the residual urine, and we can discontinue some medication like anticholinergics or ganglionic blockers they are taking, or we can titrate the dose or stop it or change the drug. And we can use alpha blocker to relax the bladder neck. We know the alpha 1 is present at the bladder neck muscle, so if we block it, so it will relax the bladder neck and help the urine to pass out. And if there is a last thing, if there is a fistula, and the normal urethral bladder mechanism is okay, but it is bypassing by leaking urine into a fistula from the urinary tract. So the patient usually will have history of any pelvic surgery or pelvic radiation, and there will be continuous urine in small amount day and night with normal anatomy and normal neurological findings. So what we can do an IV pyelogram that will demonstrate the dye leakage from the urinary tract fistula with the urinary tract vaginal fistula. So intravenous indigo carmine dye we use, and when it will leak onto a vaginal tampon. So how will it reach the vaginal area? Because there is a fistula between the bladder and the vagina. And what is the treatment? We'll surgically repair the fistula. That is the treatment of all the fistulas. Okay. So this was our main topic. In next video, we're gonna study about other topics of gynecology.